bone-protecting agents in this scenario. We know that bone-protecting agents for castration-resistant disease, metastatic, this is standard of care, no questions about this. But for this castration-sensitive scenario, it's not that clear. We do have the Matt Smith trial many years ago, which was not done on intensified treatment, was mostly ADT alone. And I think I really have that feeling that nowadays, I mean, with more efficacy, more intense treatment, we're also going to have more problems with bone health. So I'll tell you what I think after, but I'd like to hear from you guys. If you're using any bone protecting agents for everyone, or doing DEXA scans, seeing if there's osteopenia, osteoporosis, when you're starting treatment for metastatic castration sensitive disease. Anyone?
I can start. Yeah, I mean, so for us, I mean, we have a bone health clinic, and so I think that very, very important for all urologists when you're starting just to get a baseline. So getting that baseline DEXA scan for our patients is important to know where they're starting at, and then we counsel them on kind of what their risks are. You know, if they have bony mets, if they have significant bony mets, doing something that's protective is gonna, help them long term significantly. So we do talk about that with them, yeah. But you're right. In the metastatic castrate-sensitive population, it's a little more controversial than the metastatic castrate-resistant.
I use it routinely. Yeah. So I get DEXA as well, right?
Denosumab, zoledronic acid.
Every 6 months. Yeah.
The dose for every 6 months.
Not monthly, like I would in the castration-resistant patient population.
But if they have some osteopenia, osteoporosis, or for everyone on ADT?
It's a good question. So I will get a scan within 6 months of initiation of ADT. And then if they have any osteopenia, I will start them. I'll start them at that point in time. And then I'll repeat a DEXA scan within a year. Okay. And then assess their change. If they were non-osteopenic, non-osteoporotic, to see what the change is. And they usually at that point, I'll be able to start them on something in the hormone-sensitive metastatic setting.
I would agree. I usually get my first baseline study usually at the first 3-month visit, not to overwhelm them initially, to establish that baseline. And then osteopenia, osteoporosis, usually initiating treatment.
Okay. We said earlier that maybe this is not the routine anymore, but there's still someone for ADT alone. I mean, not biochemical recurrence. Let's talk about metastatic disease. I mean, still anyone using, you think that's still some room for using ADT alone for any patient?
It's the anecdotal patient.
It's tough to find.
It's the rare example.
It's the rare.
I could give you
it should be at least.
I'll give you an example. I saw a patient maybe last week, 94-year-old gentleman. He had BPH. His PCP runs a PSA. PSA came back at 28. And so in that patient, we actually didn't biopsy. We did a PSMA up front. And he had localized prostate cancer without any nodal disease elsewhere. So we kind of staged him without a biopsy, which is interesting. We talked about what his options are. And he chose to go on monotherapy, ADT. It'll probably be intermittent for him to kind of keep the disease control. But that's a kind of controversial patient. He has 94, excellent health though. He lives to be 100. Do you protect him from getting those bony mets by doing intermittent ADT? Do you add in an oral? Like that's, of course. I think it's the older patient that's the unusual patient to manage.
Yeah, it's going to be an exception. Although when we see some real world evidence again, we still see a lot of ADT being done. I think the last time that it's getting much better, but I think it's still even US, we're still seeing like 30 to 40%. Yeah, 30 something percent, which is a lot. I mean,
it's remarkably sad considering the amount of level 1 evidence that's out there. To the contrary.
Yeah, and at some point there was a suggestion for some study that patients that were seen by urologists actually were getting more ADT alone than seen in medical oncology. Well, actually, I don't agree much. I think urologists doing that are pretty, on top of that data and really pushing for doublets and then for triplets. So I really don't see that in practice. But for some reason, I don't know, the way we get this, like in the billing, the forms, or the way we get this data, end up getting that.
So if you look at the claims, I'm aware of it. Say looking at claims data, which suggests that both urologists and medical oncologists do equally poorly in that patient population. So I think that we can't be held to task there. But the point being, not only survival but time to castration resistance. These are significant endpoints, right, for these folks. They're not soft endpoints. So ADT alone should be I think the rare patient in this scenario.
It's hard to defend at this point.
Exactly.
Someone ADT alone.
Exactly.
Very hard to defend.
It's hard to justify. Correct.